Welcome to the University of Kentucky Department of Anesthesiology YouTube channel. This video cast is on respiratory topics including anatomy, physiology, and thoracic anesthesia related to the 2018 keywords. Now the 2018 keywords are listed here, and I've subtitled them under anatomy, physiology, pulmonary function, and clinical and pathophysiology. For example, under anatomy, laryngoscopic view and grading, and cricoid pressure and its effects. Under physiology, oxy-hemoglobin dissociation curve and its characteristics. Under physiology, other things like TPN and its respiratory effects, high altitude and the physiologic changes that occur when we're at high altitude in the respiratory system, bronchoconstriction and its pathways, lung compliance and how we measure it, and then under pulmonary function, the effects of obesity and aging on pulmonary function, and a goiter on flow volume loops. Under pathophysiology, upper respiratory tract infections and airway reactivity that can occur thereafter, respiratory failure and how to preoxygenate adequately, difficult airway algorithm, hyperbaric oxygen and toxicity of oxygen, placing double lumen tubes versus bronchial blockers and malpositioning double lumen tubes, jet ventilation, airway fires, aspiration management when there's an LMA in place, negative pressure pulmonary edema, the respiratory effects of laparoscopy and insufflation of the abdomen with CO2, ventilator-acquired pneumonia and preventing it, including the discussion of subglottic drainage endotracheal tubes, and lastly, near drowning. For those who want a more comprehensive keyword review on the respiratory topics, consider going to previous video cast, Respiratory Keyword Review Part 1, 2, and 3 that are on our YouTube channel. Now for our 2018 keywords, let's continue on with the first one, laryngoscopic view and grading. The top left is the classic Mallampati classification 1 through 4. You know that we should have that patient, when we're doing a Mallampati exam, sit up, lean forward, open their mouth as wide as they can, extend their tongue as far as it can go, and look in the back of their mouth and say, can I see the pillars of the tonsils, the uvula, the hard palate, and the soft palate? And if we can see all of them, we say that's class 1. If we can only see the hard palate, that's class 4. If you can't see the uvula, we can see that that's the class 3 airway. And we hope that we'll have a class 1 that will then predict that maybe when we do laryngoscopy, we'll see a grade 1 view. That is all of the arytenoids, vocal cords, epiglottis seen, as opposed to a grade 4 view where you see nothing, and a grade 3 view where you see just the epiglottis. Grade 2 is where you can see part of the vocal cords and the arytenoids. Now there's some components of the preoperative airway physical examination that I'd like to point out. There's little red stars shown on them on the top right. One is inter-incisor distance, or mouth opening, should be greater than 3 centimeters. Thyromental distance, which should be greater than 3 finger breaths. And if someone has a big old thick neck, greater than 17 inches, we say, ooh, that's a non-reassuring finding of ability to intubate this patient. Cricoid pressure is somewhat controversial. We hold cricoid pressure in an attempt to reduce the passive regurgitation and potential aspiration of gastric contents. It decreases lower esophageal sphincter tone. It can make laryngoscopic view harder and makes bag mask ventilation and the proper positioning of a laryngeal mask airway more difficult. Cricoid pressure should be let go if there's active vomiting that occurs because the esophagus can be damaged. And in the case of unstable cervical spine, pressing on the cricoid can also move the cervical spine. Thyroid cartilage pressure we often do to improve our laryngoscopic grade. When we're doing DL and we can't see so well, it's a grade 3, we reach up and press on the thyroid cartilage and hope that it becomes then a grade 2 and easier intubation. A back up to the right pressure is called a Burt maneuver, and it's pressure on the thyroid, not the cricoid cartilage, but the thyroid cartilage. The next key word is oxy-hemoglobin dissociation curve and the characteristics of such. The x-axis is the partial pressure of oxygen in millimeters of mercury, and the y-axis is the percent saturation of hemoglobin. If we go up to this curve and look at 50% saturation and trace it over to a normal curve, the dark black, And then down to the x-axis, that's about 27 millimeters of mercury partial pressure of oxygen that results in 50% saturation, or the P50 normal of oxyhemoglobin. Now, tissue pH, if it becomes very acidotic, that is one of the things that causes a right shift or more release of oxygen to the tissues. Other things that increase oxygen release to the tissues or reduced affinity of hemoglobin for oxygen is when the temperature goes up, there's lots of 2,3-diphosphoglycerate around, and again, the acidosis. Things that shift it to the left or make it release less oxygen and hold on to oxygen more is being cold, low levels of 2,3-DPG, which might be present in transfused blood, for example. Large amounts of transfused blood lowers 2,3-DPG, less release of oxygen to the tissues. A alkalotic state and carbon monoxide shifts the oxyhemoglobin curve to the left. So if a normal P50 is about 27 millimeters of mercury, some things that make it go to the far left are fetal hemoglobin, which has a P50 of 18 to 20. It wants to grab on oxygen and hold on to it. And maternal hemoglobin is a little bit shifted to the right because it wants to release oxygen to the fetus. And sickle cell is an example of a very right-shifted oxyhemoglobin dissociation curve. The next key word is respiratory effects of TPN, and the picture at the top right shows some components of total parenteral nutrition, including the yellow bag with vitamins and carbohydrates and amino acids, and then the white bag with lipids in it. The important point is that there is less carbon dioxide produced when the calories from lipids are provided as opposed to the same amount of calories from carbohydrates. And this can make it easier to wean a patient from mechanical ventilation if they have less carbon dioxide that they need to exhale. Therefore, the work of breathing is reduced. This requires understanding of the alveolar gas equation, which we'll go over next. The alveolar gas equation is used to calculate P big AO2, or the partial pressure of oxygen in the alveolus of our lung, based upon what's the FiO2, which in the air around us is 21%, what's the atmospheric pressure at sea level is 760 millimeters of mercury, and what's the vapor pressure in our trachea and bronchi at 37 degrees, it's 47. And therefore, these are used along with CO2 over the respiratory quotient, arterial partial pressure of CO2 divided by the respiratory quotient, which is subtracted from the FiO2 times the atmospheric pressure minus water vapor pressure. So we have 0.21 times 760 minus 47 minus, if the CO2 was 40, divided by a respiratory quotient, which on average is 0.8. So the far part of this equation becomes 40 divided by 0.8, or about 50. Respiratory quotient, by definition, is the ratio of carbon dioxide produced to that of oxygen consumed. And with carbohydrates, this is 1 to 1. With proteins, it's 0.8, and with lipids, there's less carbon dioxide produced to the amount of oxygen consumed, and 0.7 is the RQ for lipids, with average again being 0.8. Therefore, back to our key word, that if you provided more calories from lipids, replace the carbohydrate calories with lipids, you would have less CO2 produced, less work of breathing, possibly could wean someone from a mechanical ventilation easier. A couple other points before we move on to the next key word. If someone comes down on TPN with high dextrose containing solution like D15, don't just stop it. You can run the risk of perioperative hypoglycemia. Another point is that overfeeding or giving too many calories can actually result in a respiratory quotient greater than 1. Next key word is physiologic changes with high altitude. What happens? We hyperventilate. Our respiratory rate goes up. Our tidal volume goes up. Why? Because the air around us has less oxygen in it, and our alveolus sees less oxygen, and therefore the blood gets less oxygen in it, and the PaO2 goes down. The carotid body senses this reduced PaO2 and stimulates the brainstem to cause hyperventilation. As we hyperventilate, that increases the P big AO2 in our alveolus and also drops the arterial CO2. If we cause a respiratory alkalosis, the body compensates by getting rid of renal bicarbonate, and over time we no longer can keep that hyperventilation up because we've compensated our acid-base status. And for only a short period of time can we have this hyperventilatory response in response to this high altitude. Now, by giving someone Diamox or acetazolamide, this drug inhibits carbonic anhydrase and results in excretion of bicarbonate in the urine. It acidifies the blood so that we'll continue to hyperventilate for a longer period of time, and it also shifts the P50 to the right. And the end result is that there's better compensation when you're at high altitude, and Diamox is used for people who are climbing to high altitude or bicycling at high altitude. I have taken it personally when climbing 12,000 foot peaks several days before I was up at the top of those peaks, and it definitely helps the hyperventilatory response. Some other problems with high altitude: the low P-big-AO2 in the alveolus, when the capillaries go by that alveolus with low oxygen in it, they constrict. That's hypoxic pulmonary vasoconstriction. And if you have global decrease in P-big-AO2 because you're at high altitude and not breathing supplemental oxygen, lots of the capillaries all over your lung constrict, and pulmonary hypertension can result. You can get capillary leak and get high altitude pulmonary edema, which is called HAPE. There's another thing called HACE, or high altitude cerebral edema, that can occur when a patient can have headaches, vomiting, confusion. So being up at high altitude, we usually will hyperventilate. We can get bad things like pulmonary edema and cerebral edema. And if these things occur, we need to move the patient down to a lower altitude. Dexamethasone has been used to help, supplemental oxygen, putting them in pressure bags temporarily till you can get them down to a lower altitude. But the main point of the keyword physiologic changes was that hyperventilation is a normal response to the decreased P-big-AO2 that occurs at high altitude. The next keyword is bronchoconstriction and reflex pathways. Let's review the innervation of the lung first. The graphic at the far right shows the innervation from the vagus as well as the sympathetics. And the important point to realize is that the parasympathetics richly innervate the bronchus and the bronchioles via that vagus nerve and release acetylcholine onto muscarinic receptors, and that results in the bronchoconstriction of conducting airways. For example, if the end of an anesthetic, you went to reverse a neuromuscular blockade and you gave neostigmine alone, neostigmine would inhibit acetylcholinesterase, raise acetylcholine levels, the muscarinic receptors would be activated, bronchoconstriction would occur, and we avoid that muscarinic side effects by combining neostigmine with an anticholinergic like glycopyrrolate. Ipratropium is an example of an inhaled anticholinergic, and it works especially well in patients with COPD. Sympathetics, the innervation of the airways is sparse, but circulating catecholamines do have an effect on the airways via B2 or these B2 receptors, which when they're activated, the beta-2 receptors, you get bronchodilation. We take advantage of that with albuterol inhaled or epinephrine intravenously. This increased intracellular cyclic AMP occurs from the B2 effect, and bronchodilation is the end result. Histamine also can cause bronchoconstriction via the H1 receptor. And the major point of this keyword was that the reflex pathway for bronchoconstriction is the parasympathetics via the vagus, muscarinic receptors, and that acetylcholine is the mechanism. The next keyword is lung compliance and measurements of lung compliance. Compliance, by definition, is a change in volume over a change in pressure. If you have a balloon that you can blow up a large volume into it without much pressure inside of it, that would be a very compliant balloon. The thoracic cage and the lung make up the total compliance of our respiratory system. And in the case of aging and obesity, the thoracic cage compliance can go down, And the lung compliance with obesity is normal, and with the elderly, it actually is increased. So you can have differences in thoracic versus lung compliance, one contributing more of a problem, such as obesity and the restrictive pattern that can occur because of thoracic cage decreased compliance. We add the compliances in parallel rather than series, such that if the thoracic cage compliance is 200 mils of gas per each centimeter pressure of water, the lung compliance is the same, about 200 mils for each centimeter pressure of water. 1 over the total becomes approximately 100 mils of gas for each centimeter of water pressure is the compliance, a change in volume over a change in pressure. There's two major types of compliance that we like to talk about. One is dynamic compliance, and the other is static compliance. Dynamic compliance, again, a change in volume, the tidal volume, over a change in pressure, the peak airway pressure we use in this case, minus if there's PEEP applied. And over on the far right graphic, you can see where the peak airway pressure is obtained from. And this dynamic compliance is really reflecting resistance to gas flow in the tubing, the endotracheal tube, the airways, getting the gases out to the lung itself. And things that decrease it, if there was mucus in the endotracheal tube or blood, bronchospasm, classic cases where you have a high peak airway pressure and dynamic compliance is a problem. Static compliance, the change in volume is, again, tidal volume, but in this case, the denominator is plateau pressure, and that's the measure of airway pressure required to hold the lungs and chest wall at end inspiration when gas flow is absent and keeping them open. And so it really is a reflection of what's going on at the lungs. And if they're stiff, static compliance is reduced. Pneumonia would be an example where static compliance would be reduced. So lung compliance, a change in volume over a change in pressure. The next key word is obesity and PFTs, or pulmonary function tests. The lung compliance of an obese patient is usually normal. It's not a problem with the lung itself, but they can have a problem with chest wall compliance because of the layer of adiposity sitting on the chest wall. So in general, on PFTs, what you'll see is decreased lung volumes. In the picture up at the top right is an attempt to show that restricted lung disorder of obesity with low vital capacity, residual volume, functional residual capacity, especially important, is low, and tidal volume and total lung capacity. It is a restrictive ventilatory defect on PFTs such that there will be a decrease in both FEV1 and FVC, but when you calculate the ratio, it's greater than 80%. And we say that's a restrictive rather than an obstructive disorder. When an obese patient is put to sleep, you realize that they can rapidly desaturate when they go apneic. And part of the reason for that is the low functional residual capacity. FRC, by definition, is the gas that's left in the lung at the end of a normal, unforced expiration. So at the end of a tidal volume breath, you have given propofol, they go apneic, and they have approximately 30 mils or so per kilo. 30 to 35 mils per kilo is the normal functional residual capacity. And that is where you're getting oxygen from during the period of apnea. If the FRC is low, you're going to desaturate more rapidly. And if you're using oxygen more, which obese patients do, you're going to desaturate even more rapidly. So those two reasons, main reason why rapid desaturation when an obese patient goes apneic. Another important point with obesity is that when an obese patient is placed supine, their tidal volume breaths can actually occur below their closing capacity. And the closing capacity is where these small airways are beginning to close. And if you're breathing at tidal volumes less than that, where is the gas going? It's not contributing to effective ventilation. And so the arrow at the bottom in blue is pointing to the supine positioning of an obese patient and how the tidal volume breath can be below the red star, the closing capacity. And you can see how that patient could have a respiratory arrest just by placing him supine. And Trendelenburg makes it even worse. Keyword, major point, obesity and PFTs, it's a restrictive defect. Next keyword is obstructive sleep apnea versus obesity hypoventilation syndrome. And up at the top right is the classic stop-bang mnemonic that we use in the preoperative clinic when we're talking to patients and trying to determine if they're at risk for obstructive sleep apnea. If they snore a lot, if they're tired during the day, if they are observed to stop breathing during the time that they are sleeping, and also if they have high blood pressure. And that snoring, S, tiredness, T, observed stop breathing, O, and high blood pressure, P, are used as part of the STOP questionnaire. And part of the BANG questionnaire is, do they have a body mass index greater than 35? Are they older than 50? The neck circumference, is it greater than 40 centimeters or so? And are they males, gender, BANG? Then we can say if they have a lot of these on their stop bang questionnaire, they're at risk for obstructive sleep apnea. Now OSA, males, gender distribution more, increases, yes, with obesity. And what we classically see is that at the nighttime, this person is observed to be choking or gasping during sleep. They recurrently awaken from sleep, and they have more than 5 obstructive breathing events per hour of sleep on polysomnography testing. Obesity hypoventilation is different in that the gender distribution is male equals females, and their PCO2 tends to be elevated and their PO2 decreased during this time period of obesity hypoventilation in the middle of the night, and they don't obstruct unless they have coexisting obstructive sleep apnea. So it's really their CO2 is building up, their oxygen's going down, they're not responding appropriately, and at nighttime their CO2 is measured to be higher and the desaturation occurs, and this is not explained by them stopping breathing or by having these episodes of obstruction. So that's obesity hypoventilation. And one of the problems with obesity hypoventilation is if you have an elevation in CO2 and a decrease in PO2 over time, pulmonary hypertension can develop, and this is more common than patients with obstructive sleep apnea. The next key word is aging and respiratory changes. The lung of the elderly patient undergoes emphysema-like changes. It's easier to inflate. The compliance is more, but it doesn't snap back to smaller sizes as well. So I think of it as a rubber band that doesn't snap back as well, and therefore their residual volume is higher, the gas trapped in the lung, and FRC is increased. They have VQ mismatching that results, and there is an age-related decrease in PaO2 such that if you measure arterial blood gases from elderly patients, say for example age 90, it's not uncommon to have a normal PaO2 of about 70 or so, while yours should be in the 90s. There's decreased alveolar gas exchange surface area. Those are lung parenchyma changes. The ventilatory control problems like decreased responsiveness when the CO2 builds up, they're not going to hyperventilate as much. They're not going to hyperventilate as much to a decreased PaO2 that occurs. Their chest wall compliance may be decreased because of arthritic and cartilaginous changes. The lung itself is actually more compliant in general. Their muscles aren't as strong to move air in and out. The conducting airways don't have much changes, and their airway reflexes tend to be decreased such that it's not uncommon to do DL on an elderly patient and see residual food particles sitting around the larynx, and you think, why could that person not realize that they're present and try to clear those? So decreased airway reflex is part of this respiratory changes with aging. If we look at graphically the age on the x-axis and the volume in the lung on the y-axis, there's a couple things to point out. First of all, the blue arrows, residual volume goes up. Remember, these lungs become more compliant, emphysematous-like, more air trapping. Residual volume is air trapping, and that goes up. FRC goes up. Closing capacity and closing volume go up such that normal tidal volume breaths, as we get up in our 60s, are crossing over into our closing capacity, and therefore there's VQ mismatch occurring, which is contributing to the lowering of our PaO2 as we age. And we mentioned the lung compliance that is increased. Laryngeal reflexes, alveolar surface area, things that decreased. Major point from this graphic, though, is that closing capacity and tidal volume cross over in the 60s or so, and you can see why VQ mismatching is occurring. The next key word is flow volume loop and goiter. And the picture at the very top of post-intubation tracheal stenosis is a good example of someone who had been intubated probably for an extended period of time or with a tracheal cuff that was up at too high of pressures, more than 25 centimeters of water or so, for a long period of time, shuts off capillary blood flow, and you have scarring of the trachea and the sclerosis and stenosis that occurs. And it's a fixed obstruction. Both inspiration and expiration, there's a problem getting air down and air out of the lung. Let's go to the graphic at the top right now to look at a flow volume loop to make sure we understand this concept. Above the line of volume is expiration, below the line is inspiration. And notice the triangle-like pattern of expiration and the circular-like or hemicircle part of inspiration, or the shape of inspiration. Starting at the far right, when the volume, we take a breath in during inspiration, and then we expire out as hard as we can in these flow volume loops, then take another breath in as deep as we can, and then blow it out. And we measure the flow rates. The green arrow is to show what the keyword was based on, and that is a goiter. If a goiter is compressing the trachea, it is a fixed obstruction, obstructing both inspiration and expiration, such there's truncation of flow velocity during inspiration, it's lower. During expiration, it's lowered. And the pattern shown here is what would occur in a flow volume loop. One way to remember the effects of different things on a flow volume loop is the mnemonic that I utilize, IE and EI. If the problem is extrathoracic, in general, if it was like, and it's a dynamic one, like a vocal cord problem, that's extrathoracic, paralyzed vocal cord, you would try to take a breath in, and there would be inspiratory problems. The vocal cord would be sucked in and obstruct the airway. So if it's an extrathoracic dynamic problem, you have problems with inspiration, as opposed to if it's an intrathoracic problem, like a bronchial tumor, when you try to expire, you can't get gas out very well. So IE, EI, one way to remember a dynamic defect that can occur and you can observe on flow volume loops, whether it's an intrathoracic or extrathoracic problem. The key word was flow volume loop and goiter. Goiter is an obstruction of flow during both inspiration and expiration, and it's not a variable defect, it is a fixed defect affecting both inspiration and expiration. The next key word is upper airway reactivity. If someone has a URI, they can have bronchial hyperreactivity for up to 6 weeks or so after that resolution of the URI. This is often a problem in pediatric anesthesia population who are coming in for example, ambulatory surgery like tonsillectomy. And there is an increased risk if someone has had a recent URI of perioperative problems like laryngospasm and bronchospasm because of that bronchial hyperreactivity. They can have more coughing, episodes of desaturation in the perioperative period, and there are some predictors of adverse respiratory events. And if you're undergoing airway surgery, and this person who's had a upper respiratory tract infection recently, if they're having exposure to passive smoke in the environment that they're in, their parents smoke, for example, or if they already have some airway problems like asthma or residual BPD from being born premature, these would be patients who you'd be especially wary of if they've had a recent URI of anesthetizing them, and you would worry about bronchial hyperreactivity, laryngospasm, and potential bronchospasm in the perioperative period. The next key word is respiratory failure and preoxygenation. Let's first define acute respiratory failure. We can define it by hypoxemia. PaO2 is low despite FiO2 supplemental being given. And hypoventilation, we can define acute respiratory failure as not being able to get rid of carbon dioxide. VDVT, dead space over tidal volume greater than 0.6, and high PCO2. And then we can define it also with abnormal respiratory mechanics, where they're breathing fast or low vital capacity or can't generate a negative inspiratory force of more than minus 20 centimeters of water. So the key word was, if you have someone in respiratory failure and they're being anesthetized for surgery and you're going to have to preoxygenate them and getting ready them for a short period of apnea, what do you do to make sure that they're adequately preoxygenated? And the important point is that you want them adequately denitrogenated, and one way to detect that is during the time that you're preoxygenating them with a mask in place, measure the end-tidal oxygen. And when the end-tidal oxygen is greater than 90%, this is considered gold standard to document that you've replaced what's in their alveolus. The nitrogen in their alveolus, nitrogen makes up 80% of air. We get rid of that. We've replaced in the alveolus oxygen, and that person is ready for a short period of apnea and hopefully will not desaturate as rapidly. The SpO2 is not a good indicator of optimal preoxygenation. Just because they're reading 99% sat, they could have a PO2 in their blood of 95 or 600. And they may not be adequately denitrogenated. Using CPAP or pressure support during preoxygenation can actually prolong the period of apnea to desaturation. And in obese patients especially, I often will add some pressure support with a tight mask, ask them to breathe with it, and it can help give you a little bit more time after the period of apnea before desaturation. Some factors that decrease the safe apnea time are a low functional residual capacity, the obese patient or the pregnant patient. They desaturate more rapidly. Shunts, increased oxygen consumption, someone with a fever, using more oxygen, and inadequate preoxygenation. And we're going to avoid that by monitoring end-tidal oxygen to show that we've adequately denitrogenated the patient. Difficult airway algorithm. This you've followed multiple times, I suspect, and you know that if you cannot intubate and cannot ventilate someone, the supraglottic airways, such as an LMA, can bail you out of this situation. However, if you place an LMA in this situation in an attempt to be able to convert a cannot intubate, cannot ventilate scenario to a can ventilate scenario, and the LMA fails for some reason, and the patient's desaturating, you're unable to ventilate, the LMA has failed, an invasive airway is the next step in a cannot intubate, cannot ventilate scenario, cricothyrotomy. Gap in knowledge in 2018 was related to airway and facial edema that can occur when an ACE inhibitor like lisinopril is started, even after the first dose in some people. The picture at the top right shows an African American who got an ACE inhibitor and very shortly thereafter developed tongue edema, airway edema likely, and these patients need to have airway management quickly, often in an emergent situation, often a wake fiber optic or even a surgical airway may be required, because what has happened is the ACE inhibitor not only is inhibiting the breakdown of angiotensin 1 to angiotensin 2, but it's also inhibiting the breakdown of bradykinin. Bradykinin has the major hypotensive effect of an ACE inhibitor because bradykinin is a vasodilator, but bradykinin is also the cause of the cough that's often associated with these ACE inhibitors. The thing we're talking about here, angioedema, and the taking of a lisinopril or another ACE inhibitor and the rise in bradykinin that can occur can result in this angioedema and an emergent situation. The next key word is hyperbaric oxygen and the indications for HBO therapy. If someone has had an air embolism, I had this occur during a liver transplant. I've had it occur during cardiac surgery. And you may have air embolization during a sitting cranie. And if a massive air embolus occurred for whatever reason and the air went to the head, one way to try to resolve that air in the head is HBO therapy. Carbon monoxide poisoning is another potential indication for HBO therapy, especially if they have very high carboxyhemoglobin levels, or if they're pregnant, or if they're having angina, or if they're having bad CNS dysfunction, they're very can't think straight, mental disorder from the poor oxygenation, you should think of HBO therapy if they've been exposed to carbon monoxide, rather than just giving them oxygen and waiting. Cyanide poisoning, while you're administering thiosulfate as a sulfur donor to bind with cyanide to be excreted in the kidneys as thiocyanate, as you're maybe given vitamin B12 in large doses, cyanocobalamin or amyl nitrate to convert oxyhemoglobin to methemoglobin, which then can bind the free cyanide. Those are treatments for cyanide poisoning. HBO therapy may also be utilized. Gas gangrene, bad infections, anaerobic infections, and other things are indications for HBO, but gas embolism would be right up near the top. Some toxicity of oxygen. HBO therapy is often at about 2 or 3 atmospheres and often at 100% oxygen, so you can calculate that the PaO2 is very high in these patients if you used your alveolar gas equation, over 2,000 or more. And if a patient had an oxygen-induced seizure, the treatment is just to reduce the inspired oxygen. Don't decompress the chamber because you can get in problems with inability to failure to exhale during the seizure, and you can get barotrauma. So don't decompress, just decrease the inspired oxygen, and rarely is there any sequelae from this HBO-induced seizure, and they can continue to have HBO therapy. And it's not more common in patients with actual seizure disorder. So you don't need to give midazolam or propofol to stop the seizure, just reduce the inspired oxygen if it occurred during HBO therapy. Now, in patients that are given high concentrations of oxygen over long periods of time, they can get oxygen toxicity. It can occur in the lungs, the brain, and the eyes are the major targets. In the lungs, exposed to high concentrations of oxygen, such as 100% oxygen, for like 10 to 12 hours even, just a short period of time, they can have tracheobronchial irritation, and the patient will be coughing, they'll complain of burning chest pain, and even can get ARDS-like symptoms. In the brain, other than the seizures, they can have nausea, vomiting, and twitching. And in the eyes, they can get changes in their visual fields and their ability to refract and see well. So the lungs, the brain, and the eyes, oxygen toxicity targets. These are symptoms of oxygen toxicity, such as tracheobronchial irritation in the lungs. The next key word is double lumen tube versus bronchial blocker. We can separate lungs and differentially ventilate one lung over the other using several different types of apparatus. Double lumen tube up in the top right, usually left-sided, a bronchial blocker which can be passed down alongside an endotracheal tube or built into the endotracheal tube and passed down either the right or left side to block it. And even simply an endobronchial tube that's advanced into either the right or the left mainstem can be used as a simple lung separation device. Now, what are some benefits of a bronchial blocker? They are shown in the green plus signs. Some potential downsides of a bronchial blocker are shown in the red negative signs. So let's look at the positives first. With a bronchial blocker, when you've tubed someone and the tube's in the mid-trachea, it's easy to recognize the position of the carina. With a double lumen tube, sometimes we put it down too far and we get mistaken about what's the right middle lobe versus the carina, and it's hard to position sometimes. So a little bit easier to recognize the anatomy. Best device if you have a difficult airway. Think about that. If you have Malampati 4 and other components that would predict that a patient's going to be difficult to intubate, and you're trying to put this big old double lumen tube down, it's much more difficult than putting a, for example, bougie in an endotracheal tube or a glide scope with a simple single lumen endotracheal tube. So best device for a difficult airway, put the single lumen tube down, then the bronchial blocker next to it or through it. At the end of a case, such a thoracic case, if the patient's going to remain intubated, you don't need to replace the tube at the end, such as we often do with a double lumen tube. Now, you can use a double lumen tube, take them up to the floor, take the bronchial blocker down, for example, or the bronchial cuff down, that is, with the double lumen tube, and ventilate someone with a double lumen tube, but it's much more difficult. So if you're going to need to replace a tube at the end, double lumen tube would require that, bronchial blocker would not. You could just pull the bronchial blocker out, you'd have your single lumen tube in place. The other thing that's good about a bronchial blocker is you can't just block the main stem bronchus of the right or left side. You can actually pass that bronchial blocker out and block at a lower lobar level, like the right middle lobe, and then still be ventilating the upper and lower lobes. The problems with a bronchial blocker is it has a small channel for suctioning. It's harder to get the secretions out. There's a high chance of dislodging it, at least more than a double lumen tube. And so the maintenance of having to go down and look and check it and make sure that it's in place is more difficult than a double lumen tube. Some malpositions of the double lumen tube is the next key word. Let's first review, what if you have lung isolation, or you think you have adequate lung isolation, and you start one lung isolation and you have precipitous desaturation. Don't forget that if the saturation goes down to like 70% or low 80%, just go back to 2-lung ventilation and reassess what's going on. But if you have a gradual desaturation, one of the first things that you should do is ensure that you're really delivering 100% oxygen, and check the position of your double lumen endotracheal tube or your bronchial blocker with a fiber optic bronchoscope. Now let's look at the top right of what would happen if the double lumen tube was down too far, up too far, or out the right side. First, I'm going to point to a double lumen tube that has gone all the way deep in the left side, and you can see that if you tried to ventilate through the right side only, there would be obstruction of gas trying to get past that bronchial cuff, and you would have high peak airway pressures. If you clamp the left side, tried to ventilate the right side, you wouldn't be very effective. The left, if you clamped the right and ventilated the left lung would go up and down, and you would hear breath sounds on the left side. In this case, if you put your fiber optic scope down, you should be able to identify that it's deep. If the tube didn't go down too far, let's say it's at 25 centimeters of depth, and you didn't realize it, and you had this double lumen tube sitting in the mid-trachea, and you tried to ventilate through the right side with the left clamped, you could see that it would be very difficult to get any air to go anywhere, because it's likely that the bronchial cuff would obstruct the trachea. In the case of the far right, you can see a tube that's been passed, instead of going out the left side, which left-sided tubes are usually used, it has gone out the right side. And in this case, you can see that if you tried to clamp the left side and ventilate through the right, you're not going to get much gas going out to that right lung because the cuff is going to block the passage of gas. So tube malpositions with left-sided double lumen tubes can occur. We should take the scope and go down and look. And so in the bottom right is an example to show you what it looks like through a scope, first of all at position A at the carina. Now, when you see the carina here, many times if you're not used to looking through a scope and putting double lumen tubes, you can get out too far sometimes, and B, it kind of looks like carina, but what's that division on the left side? You're thinking if your tube was down deep and you were seeing this, you might think it's properly placed, but that would actually be a right side down too far of that double lumen tube. But you should see initially, if you're looking through your tracheal tube, the carina here at A, and what I often do is take my scope and go all the way down and look at the right upper lobe and confirm the takeoff of the 3 little openings. And if you go down the left-sided tube, you should be able to see the takeoff of the left upper lobe. Now let's go back to our gradual desaturation situation where you've checked the position of the double lumen endotracheal tube. Ensure that the blood pressure is okay and the cardiac output's okay. Recruit the ventilated lung with increased peak airway pressure. Hold it open for a while and then release it. Add PEEP to it of 5 centimeters of water. And then you can start adding CPAP to the non-ventilated lung after you've recruited it. You can do intermittent reinflation of the non-ventilated lung, but the surgeon's not going to be real happy with that lung occasionally going up and down. And then if you're going to be taking out a lung, clamping the pulmonary artery on that side will stop the shunt of blood going to the lung that's not being ventilated, make all the blood go to the lung that is being ventilated, and your saturation will rise dramatically. So if you're going to do a total pneumonectomy anyway, and you're having problems with desaturation, clamping the pulmonary artery is the most effective way to raise your saturation. The next keyword is jet ventilation complications. In the picture at the top right is probably an ENT procedure with a jet ventilator attached. Jet ventilation is often used for rigid bronchoscopy, airway surgery, and after catheter cricothyroidotomy. Now there are several types. There's a high-frequency jet ventilator, or just the garden variety low-frequency, where you manually trigger a handheld jet device. The manually triggered jet device is shown on the far right, in this case with an angiocatheter through the cricothyroid membrane into the trachea, and you're depressing a device that's releasing a high-pressure jet into the trachea through that catheter. The device on the far right is the example of a high-frequency jet ventilator, often used now in ENT surgery such as tracheal resection surgery. Now, there's some complications of jet ventilation, which is the keyword topic. One is that oxygenation is often good during jet ventilation, but the PaCO2 builds up as hypoventilation ensues. If a patient's apneic, totally apneic, the CO2 tends to build up about 6 millimeters of mercury the first minute and 3 to 4 millimeters of mercury each minute thereafter. Now, during jet ventilation, they're not totally apneic, and the CO2 is building up slower than that, but it is building up, and you can get a respiratory acidosis, cardiac dysrhythmias from the respiratory acidosis, and those are the major complications. Hypoventilation with a buildup of CO2, and then the side effects of that buildup of CO2 being respiratory acidosis, dysrhythmias like ventricular premature beats. Another complication, though, is if you're jetting at high pressures, you can see why you could get barotrauma, pneumomediastinum, pneumothorax, this high-pressure gas source and inadequate time to get the gas out of the lung and keep jetting in more. You can cause barotrauma, pneumothorax. The next key word is airway fire management, and to decrease the risk of an airway fire, for example, when you're using a laser, one of the first things you can do is reduce the flammability of the endotracheal tube. If it's going to be in place, why not use a flexible stainless steel one, which is much more resistant to lasers than a PVC tube? The example at the top right is a non-cuffed and a cuffed stainless steel flexible tube. With the cuffed tube, sometimes it's filled, the cuff, with saline or methylene blue, such that if the laser hit the cuff and burst it, the blue, methylene blue, would show up in the airway and you'd say, aha, the cuff got blown. Another thing that you can do other than using a flexible stainless steel endotracheal tube is to reduce the available FiO2 to the lowest level possible, and that's usually less than 30%. We don't use nitrous because nitrous can support combustion also. So before the laser fires, ensuring that the FiO2 is less than 30%. And a third thing to do is just remove any flammable material that's in the airway during when the laser's being fired, and that would be, for example, an apneic technique where a small endotracheal tube is passed, the patient's ventilated, the tube is removed, then laser occurs, and when the patient desaturates, the tube is placed back down, often by the ENT surgeon, and you ventilate them back up. Management of an airway fire, which is really what the keyword was based around. If we follow the ASA practice advisory from 2013, if an airway fire occurs and the tube is in place, you see smoke and fire coming out of the airway, immediately without waiting, get that tube out, pull it, stop the flow of all airway gases, flood the surgical field next with saline, and reestablish ventilation with a mask. Tube them, and consider bronchoscopy if pieces of endotracheal tube might be stuck in the airway. But the take-home point, first step, remove the tracheal tube. The next key word is aspiration management when someone has a laryngeal mask, airway present. A discussion of risk of aspiration pneumonitis should include what is the pH of the fluid that comes up and how much came up and went down into the lung. If the pH of the fluid that comes up and goes into the lung and is aspirated is less than 2 to 2.5, that's especially risky. It's an acidotic or an acid fluid which burns the lung. And the more of it, the more chance that it's going to damage the lung. Now, pH tends to be the most important because, as you probably know, you can aspirate large amounts of blood or saline without large changes in lung function. But if you aspirate even in this 0.4 to 1 ml per kilogram range of acidic fluid, you can get a aspiration pneumonitis. How do you treat it? If they're aspirating, lateral head position, suction the pharynx, put the patient in Trendelenburg position, intubate them. In the case of if they had an LMA down, you suction around it, remove the LMA, put a tube down, suction the endotracheal tube, give them positive pressure ventilation with some PEEP. don't put saline or bicarbonate down, which will spread the acid even farther out into the alveoli and cause more problems. You don't need to check the pH of the endotracheal tube secretions. If there's big particles of food or other things that have come up and might be blocking airways, getting out a bronchoscope and looking and removing those food or large particles. Don't give them prophylactic antibiotics unless there's evidence of a secondary infection develops. And steroids don't seem to have a role here. You can follow the patient with white blood cell counts, chest x-ray, right lower lobe especially being at risk for where the aspirant could go because of the right and left mainstem angles that favor fluid going down the right mainstem as opposed to the left, and follow arterial blood gases. So aspiration management, if they had an LMA in and they were aspirating and it got down into their lung, you're going to remove the LMA, you're going to intubate the patient, you're going to suction the endotracheal tube, and then you're not going to put stuff down it like saline or bicarbonate or give them prophylactic antibiotics or steroids. Negative pressure pulmonary edema is the next key word, and its physiology. The classic presentation is you have a young male, strong chest muscles, you extubate them, and they develop laryngospasm. You may not even recognize it at first because they stay saturated, but then you realize it and you start to do things like positive pressure ventilation, pushing hard on Larson's point to try to break the laryngospasm. You give them a propofol bolus, which is to deepen the anesthesia, their level, so that they hopefully will break the laryngospasm. And then finally, if it doesn't break, you give them succinylcholine. The large negative interthoracic pressure during attempted inspiration against the obstructed closed vocal cords, the laryngospasm vocal cords, results in a high interthoracic pressure that I like to think of as just like sucking fluid into the alveolus. And when you relieve the obstruction, you tube them, finally get an endotracheal tube down, suddenly pink frothy fluid comes pouring out. And the picture at the bottom right is an example of that pink frothy fluid that just fills the endotracheal tube. I have personally seen over 1.5 liters of fluid come out an endotracheal tube after a negative pressure pulmonary edema episode. The stars, 2 of them in the graphic on the top right, is meant to point out some of the physiology of this upper airway obstruction, followed by relief and pulmonary edema. The pulmonary artery pressures go up high, so you have hydrostatic increase and forcing fluid out the pulmonary capillaries into the alveolus, and there's a leak in those pulmonary capillaries with transudation of the fluid, and this pink fluid comes out after relieving obstruction. And it's related to the large negative interthoracic pressure, often after laryngospasm. It's not the heart that's causing that pulmonary edema per se. It's non-cardiogenic. The next key word is laparoscopy and respiratory effects. There's 2 major things that occur during laparoscopy. The first is pneumoperitoneum, where CO2 is usually insufflated into the abdomen, and often accompanied by either a head up or head down position, which can also affect respiration. But we're really focusing on the pneumoperitoneum effects. In the graphic on the far right, if we follow through the increased intra-abdominal pressure that occurs initially with insufflation, causes a shift in the diaphragm, it pushes it up cephalad, which raises interthoracic pressure, which decreases chest wall compliance, which collapses alveoli, which raises pulmonary artery wedge pressure when you have collapsed lung and the vessels in the lung are constricted, and it can raise, that is, pulmonary artery pressure. FRC goes down, and all of those things together contribute to increased work of breathing. And now if a person was breathing spontaneously, which they usually are not during laparoscopy, we usually have them with neuromuscular blockade, this CO2 could build up dramatically. We usually increase our minute ventilation to compensate for that insufflated and absorbed CO2. So CO2 goes up, hypercapnia can ensue, and if they weren't paralyzed, respiratory rate would need to go up. The patient would be working harder to breathe. And so those are some of the respiratory effects of insufflation of CO2 and an increase in intra-abdominal pressure that occurs during laparoscopy. The results are there's an increase in PaCO2 end-tidal gradient, which normally in a awake state is only about 5 or so. Our PaCO2 might be 40 at a time of our end-tidal CO2 is 35, and in a sleep state it often goes up to 8 or even 10, such that there's a difference of arterial CO2 being, let's say, 45 at a time that our end-tidal CO2 is 35. A respiratory acidosis from the absorbed CO2. One of the things that don't forget is that during laparoscopy, the endotracheal tube can actually migrate. And I've had cases of obese patient, laparoscopy put in a head-down position, the diaphragm moved cephalad, and the tube actually migrated down the right mainstem. There was a sudden rise in peak airway pressure, a drop in SpO2, and the problem was that the tube was mainstemmed down the right. Pulmonary hypertension can occur from the elevation in CO2 as well as the alveolar collapse and vascular collapse, increasing pulmonary vascular resistance. The lung is less compliant. FRC and lung volumes go down. So these are the respiratory effects of laparoscopy to think about. The next key word is ventilator-acquired pneumonia and subglottic drainage endotracheal tube. I've combined them together because one of the major indications for a subglottic drainage endotracheal tube is an attempt to prevent nosocomial pneumonia or ventilator-associated pneumonia. When someone has an endotracheal tube and is mechanically ventilated for an extended period of time, there is a risk of them developing ventilator-associated nosocomial pneumonia. The early onset of ventilator-associated pneumonia usually is bugs like strep, influenza, and staph, and it occurs like 48 to 72 hours after intubation and ventilation. Late onset VAP is worse bugs in general, like Pseudomonas, and that occurs more than 3 days after intubation and start of mechanical ventilation. Now, if someone has had 4 days of mechanical ventilation, endotracheal tube in place, and they start to develop pneumonia, that is a ventilator-associated event by definition, and the diagnosis is often made by seeing bacteria actually present in bronchoalveolar cells, or when bacterial growth exceeds certain thresholds, like a bronchial alveolar lavage that we do up in the ICU, having lots of bacteria in it. The picture at the right shows a subglottic drainage endotracheal tube where there's a suction opening above the cuff of the endotracheal tube, and when that's placed to suction, the secretions that are in the posterior pharynx and that might go down around the cuff and into the lung, and we know that can happen. Things can pass by that cuff very easily. If we're removing them regularly, it can reduce the risk of ventilator-acquired pneumonia. So to decrease the risk of VAP, wash your hands. Put the head of the bed up at 30 degrees or greater to help out. Don't suppress all the acid in the stomach of every patient up in the ICU. Only do it for high-risk patients, because we found that GI acid suppression therapy, if you reduce the acid, there's more bacteria that grow in that stomach, and when they come up and go down into the airway, can increase the risk of having a ventilator-acquired pneumonia. And then oral decontamination with chlorhexidine. Washing the mouth out with chlorhexidine may decrease the risk. Last couple slides, near drowning management keyword. What do we do if someone's pulled out of the water? Let's look at drowning pathophysiology. Some patients, when they go into the water, the fluid around their laryngeal structure causes the vocal cords to slam shut, and fluid is basically just in the oral pharynx in the larynx. Now, some will gasp and fluid will go into the lungs. If that fluid goes into the alveolus, it's obstructing ventilation, and you have continued blood flow going by that alveolar unit, so you have VQ mismatch, not ventilating but perfusion going by, and you can see why they would have a decreased oxygenation. If the fluid went into the alveolus and it was salt water that is hypertonic, greater than 0.9, and normal saline, if that salt water is sitting in the lungs, it's going to draw fluid out of the bloodstream, suck it into the alveolus itself, and can actually cause hypovolemia and hemoconcentration in the blood. If it's fresh water, it's hypotonic, and it goes into the lungs, and then it's absorbed into the bloodstream and causes hypotonicity, and can hemodilute, can lyse red blood cells, and increase the volume of the patient. So salt water can be hypovolemic patient, fresh water can be hypervolemic and lysed red blood cell patient. That's the pathophysiology, but what do we do if we pull them out and are starting CPR? The new CPR recommendations for cardiac tend to say just go right to chest compressions, right? Well, if you witness a patient drowning and you pull them out of the water, 2 rescue breaths first and then chest compressions if they do not respond when you pull them out and start breathing on their own. This differs from cardiac arrest due to other causes, where CPR usually begins with immediate and uninterrupted chest compressions. I want to throw in one last topic, although it wasn't a key word from last year. It's an important one, point of care ultrasound related to the lung. The differential diagnosis of problems with the lung related to what we see on lung ultrasound. The first one simply is lung slide or pleural slide. And when we look at the pleural line, which is shown in the graphic on the far right, and a patient is breathing, that pleural line moves back and forth, and looks like little ants running back and forth. And when that's not present, we worry about pneumothorax on that side. So lung ultrasound, looking at the pleural line movement, can suggest if there's pleural slide, we say that's not pneumothorax. If there's absence of pleural slide, we think that could be pneumothorax. And so lung sliding, after placing a central line, for example, if peak airway pressure is up, we put a ultrasound on to make sure that we didn't drop a lung. B lines, or comet tail or rockets, are shown in the graphic cartoonish on the very top, and then in a real ultrasound in the middle. You can see these things that look like they're little comets or rockets, and multiple of these present suggest that there's some alveolar interstitial process like fluid in the alveoli. And the presence of these, as well as a pleural slide, suggests that they don't have a pneumothorax. And the B lines, the thing that you need to remember is that if you see those, think of some alveolar interstitial process. No lung slide, think of pneumothorax. And then A lines, these repetitive patterns at equal distance from each other, in between them, is really just a reverberation artifact from that pleural line, and that is a normal finding in normal aerated lung with normal pleural reverberation. This ends the 2018 key words, pulmonary topics, and a picture on the right is the California coast. If you ever get a chance to drive, or even better, bicycle the California coast, as I did in September 2018, 1,000 miles with my tent and sleeping bag, it's an awesome trip. See the California coast. I highly recommend it. Keep studying and learning, and have a great day.